but most people did pretty well. So, did you guys enjoy that? More hands-on, feel empowered?
Yes.
During these next few months before you graduate, when we do like the IV lab and things like that, feel free to use the ultrasound machine in practice. We'll do ultrasound guided IVs, things like that. Pull it out, continue to use it. And then, like I said already, last block, when you get to phase 2, document every single time you get to do an ultrasound or any procedure, or even if you witness or first assist of a procedure, keep a spreadsheet if your unit or your phase 2 site's not doing it, of all your procedures. That way when you get to your first duty station or your first job for those guard and reservists, you can request credentials in like ultrasound and certain procedures, so it's really good. So now we're going to start with fun stuff, trauma. Trauma's pretty fun. You guys agree? Are you more nervous with trauma or more excited about it? Who thinks trauma's pretty sexy? Yeah, it's sexy stuff, right? The stakes are higher, but honestly, the patients are easier to manage. And I say that because as long as you know the alphabet, as long as you put the X first, as long as you know the alphabet and you go in order, you can be successful at managing traumas. You just address everybody the exact same way and do the exact same thing, and you don't go on to the next letter until that particular letter is stabilized. Does that make sense? So who here, by show of hands, has participated in a trauma before? So we got a lot of experience in this room. So that's quite a bit. Who here has served as EMS, pre-hospital? Okay, quite a few folks. Who here has been at a dangerous scene, picking up a patient before and had to worry about your own scene safety or BSI? Quite a few, okay? That's important stuff. And we in the hospital, have the luxury of not having to worry about that most of the time, right? So mad respect to your pre-hospital providers. It's really easy to be an armchair quarterback and criticize everything that happens when that patient comes in. Oh, look at them, they didn't even do this right or this right. You have no idea what those folks are going through at the point of injury. So mad respect to those. Always make sure that you train them, give them constructive criticism, but not enough to like completely deflate a young 18-year-old EMT or something who's inexperienced, right? All right. So remember, I told you guys a little bit about my own background. Not that I like to talk about myself, but I graduated IPAC and was thrown into invading Iraq I had a 2-week ER rotation at Fort Carson, and so my only job now is to project all of that trauma onto you every single day while the rest of the time is here, so that you're more prepared than I was. Okay, I had to use Tent Nelly. There should be a 10th edition coming out soon, it's just not out yet, and that's why it's structured this way. So what the focus of today is understanding the primary, secondary, and tertiary surveys and what has to be done in each of those. Focusing more on the primary survey. And this is in the hospital environment. So today I'm going to cover hospital environment, like your BAMC trauma bay, where there's everybody and their mother is in that trauma bay, all right? But we know as military clinicians, that's not the environment we get to operate in most of the time. So we're gonna cover that environment in the military medicine lecture. And if you've noticed on Canvas, for those of you that tried to download the presentations, I only have this lecture up. And the reason for that is I normally go in order, but I noticed in our schedule that we have a long break. We have like a week off in between the eMed stuff, and then we start, and we have like 2 more lecture blocks, then we have another almost week, and we do our lab, and then we have the exam. And so because of that, I would like to postpone the airway part until we come back after that break. And the reason why is because the majority of your exam is on the overarching concepts of the primary survey, this lecture, and airway management. Now all those other injuries are injuries of importance, but I think they're less emphasized. Now, do you all agree that that's a good approach, or would you rather me just go in order? I'd like you to have that airway stuff fresh. And I know how your brains are. Right now you're focused on whatever's next, right? Your 50-meter target. And so I want you to have some of that stuff a little more fresh in your brain as we're approaching the eMed exam. Does that sound fair? So if it's okay with you, I'd love to cover military medicine and abdominal trauma tomorrow. And then I did pre-record heat and cold injuries because we as military folks, we know some basics about heat and cold injuries. I already pre-recorded them. I'm happy to cover them in lecture as well. If there's an opportunity on, let's say, a Friday afternoon where you'd rather go home and listen to those instead of listening to me, we can have that discussion and you guys can tell me what you think. I like to treat you guys as adults. Anyway, so we'll talk about that. But tomorrow we'll cover military and abdominal, so I'll load those lectures this evening. Sound good? I promise I'm only adjusting for you. This has no benefit to me whatsoever, okay? I can do any of them in any order. All right, but I just want to do what's best for you. Okay, so here's some of the things we're going to talk about. I'm going to kind of educate you on the background of a trauma system and what it takes to become a level 1 trauma center, what the criteria are. And then we're going to cover the components of that, the basic primary survey, each of those little individual components we're going to go over individually. Who here has taken ATLS before? Advanced Trauma Life Support. Good. If you guys get to phase 2 and they offer that, try to get on it. Same with ACLS. That's just a certification. I personally, and I don't think Hagen Williams does either, we don't necessarily resuscitate patients based on ACLS, and there's a lot of ATLS that I fundamentally, vehemently disagree with. But I have to have that certification to practice in the areas that I practice. So they still teach, give crystalloid or lactated ringers, stuff like that. We know that fluid in trauma is bad. Crystalloid fluid in trauma is bad. We're going to cover some of that. We're going to talk about some of the injuries of importance and some of the adjuncts to our primary and secondary surveys. Okay, you with me? We're going to make this as fun as possible. I put a couple of YouTube videos that you can watch. One's called Citizen Surgeon. This guy, he's like a pediatric surgeon. He kind of goes through what he thinks the primary survey should be. That's decent. It kind of follows the ATLS principles. And again, ATLS is a fundamental principle and set of guidelines set by the American College of Surgeons, who gets paid quite a bit of money to make sure that you're certified. So when you want to be certified, you pay thousands of dollars, get certified, and you carry that certification for a finite amount of time. The point of ATLS, I don't know, does anybody know how ATLS got started? Anyone? So apparently a surgeon of some sort, I think he was an orthopedic surgeon, was in a small aircraft and it crashed. He was on the aircraft with his family, like one of those private jets or something, and it crashed. And the first responders were not giving his own family the type of care he thought they deserved. And they were inexperienced, right? There was no set of guidelines and principles. So he kind of started the whole ATLS and American College of Surgeons, and it's just kind of evolved from there. Now it's a set of principles that we kind of follow, but, you know, again, fundamentally I have some disagreements with it. Okay, so remember I said if you know the alphabet, you're going to know how to do a trauma patient, right? The only thing is that we have to consider rapid blood sweep or exsanguination first. So we're going to start our alphabet with X and then go through the rest of the alphabet, A, B, C, D, E, F, G. All right, X means exsanguinating hemorrhage or hemorrhage, so we're going to stop the bleed first, okay? So if they're bleeding, where can people bleed? There's 6 main places they can bleed. Into the environment. That's bad. You can actually visibly see them losing blood. Where else? They could have an intracranial bleed. Okay, there's 7. Okay, where else? Chest, abdomen, retroperitoneal area, extremity, like a big femur fracture, and then lastly the pelvis. And how much blood can the pelvis or abdomen hold? All of it. Okay, every single red blood cell you have in your body. Okay, so we're going to talk about rapid blood sweep. Airway with C-spine control that goes together, because we're not going to just slam our airway adjuncts in a patient and not remember that they could have a C-spine injury. But of that, what's the priority? Once we have stopped bleeding outside that we can stop, that's amenable to stopping, we're doing airway focus. Is C-spine really at the high priority for us right now? What could kill them? Probably the airway, right? We're going to talk a little bit about that. Breathing. Okay, breathing, what does that entail? Yeah, assessment of effort, right? How fast, how slow, their effort, is it paradoxical, that kind of thing. Do we actually hear breath sounds? Great. Then we go on to circulation, and what does that entail? We've already stopped the bleeding, right, that we can stop. What if they have internal hemorrhage? What do we do in circulation? What's our goal there? 2 large bore IV access. How large? 16 to 18 gauge, if you can get it in. Are IOs really good at resuscitating patients? IOs are great for access and giving medications, but can we really resuscitate a patient through an IO very well? Not so much. Okay, we're going to talk about that, but it's better than nothing. But so we try to get 2 large bore IV peripheral accesses, because 2 is 1 and 1 is none, right? And then we're going to optimize circulation there. We're going to optimize that blood pressure. We're going to keep that systolic above 90. All right, that's very important. All right, disability. What is that? That's a favorite thing that you guys love to do, and you're so good at it. Calculating the Glasgow Coma Scale. Remember that? Too soon? Okay, I'm just kidding. We're all terrible at it. In fact, at BAMC in the trauma bay, there's a big sign on the back walls. When you're in there watching, you can't tell, but right behind you, there's a big sign actually, because we're at the head of the bed looking, and we can actually see it because we need reminders as well. So disability is a Glasgow Coma Scale, plus major deformities like a giant femur bone sticking out of their thigh. That's considered deformity or disability. Exposed environment. What does exposed mean? Yeah, you gotta expose your patient, but what about environment? What's that? We also need to consider already stopping hypothermia, because that's part of our diamond of death, right? Hypothermia is bad. And most trauma bays, with the exception of AMC, most trauma bays are really hot in there. When you're in there, you're working, everybody's sweating. I don't know what's wrong with BAMC and the thermostat. It's freezing, it doesn't matter what room you go into, but it's supposed to be theoretically warmer for the patients to help them prevent hypothermia. Fast, that we go into F fast, E fast, and fingers. What does that mean? So we're doing an E fast on all trauma patients. Do we have to do them on every single trauma patient? We usually do for good practice, but remember, who are the patients that we have to do an E fast where it's most applicable? Undifferentiated hypotension, usually from blood trauma, but it can be from penetrating trauma, but if it's a hypotense, traumatically injured patient, they can't go to CT, right? They're hypotense, they're unstable. So that's where the EFAS is even most valuable, although we usually do it on everybody. And especially at a training center, we like to do it on everybody. And then I added G, this is not in any references. If they're stable, this concludes the end of your primary survey. If they're stable, they're going to go to CT, because a trauma surgeon are going to want to know where the injuries are for operative planning and management. Does that make sense? But we never send an unstable patient to CT scan. So what's an unstable patient? They don't have a secured airway. If they're hypotense, right? Maybe if they have a huge intracranial bleed and they're posturing, they're about to herniate, they probably are too unstable for CT. But for your test purposes, consider blood pressure parameters. Vital signs are vital, okay? So if you have to make a decision on your vignettes, make sure you don't send an unstable, hypotense, less than 90 systolic pressure, especially when it's coupled with tachycardia. That's a hemorrhagic shock until proven otherwise. Do we all agree? Okay, good. All right, go to CT scan if they're stable. All right, so let's get into this a little bit. Let's start with the warm-up case. Why don't y'all read that for me? You read it to yourselves, and we can talk about it. You have a question, sir? Oh, yeah, we forgot to do that part. That's where we, after we log roll the patient, we'll stick a finger into a gloved, lubricated finger into the rectum, and we're checking for 2 things, just tone and gross bleeding. That's it. That's important. So that concludes the end of our primary survey. So at the very end, we go head to toe. A lot of times we'll get down to the end, we'll roll the patient, we'll check their back for step-offs, and at the end of that, they do a quick rectal check. Again, just gross bleeding and tone. We're not doing any kind of squeeze your butt cheeks together. I don't know which cranial nerve that does exactly, but we're not doing that. It's just tone and bleeding, okay? And then they can go to the CT scan if they're stable. So let's do a warm-up case. Okay, so I haven't asked a question yet, but what
what are y'all thinking about this patient? He's a 45-year-old, he's unrestrained, this is the vehicle, that looks like a significant mechanism, right? So that's kind of not good. He was ejected from the vehicle, that's also not good, but he's alert, talking, a little bit belligerent, he smells of alcohol, and it says he's intoxicated. EMS brings the patient in with his C-spine precautions, so he's on a backboard, he's got a C-collar in place. These are his vital signs. He's not complaining of everything or of anything, but he does have evidence of head trauma and some facial lacerations. So right away, what are we worried about? So bleeding, right? We want to get the bleeding under control, right? Can you bleed a lot from a scalp laceration? Yeah, especially if you're on anticoagulation, those older folks. So you want to get direct pressure on that right away. And then also make sure that these facial lacerations aren't causing him to have an airway obstruction. That would be bad, right? So we may have to secure the airway in this person. All right, very good. So in this case, again, sticking with X, A, B, C, D, E, F, G. Okay, I just want to go through it all just as a scenario. So X, we're doing direct pressure on the scalp lacerations. It says he has multiple facial lacerations. What do we need to check when we're up there at the airway? Yeah, make sure there's no instability, make sure there's no foreign bodies, make sure he's able to control his own secretions, right? Or phonate. If I say, hey buddy, are you okay? He's like, yeah, I'm okay. Instead he was alert. He's able to talk, then that's phonation. He can probably have his airway secured. All right, breathing. What are we going to assess with breathing? And I'm going to go through this again. We're going to auscultate, but we have to expose, look, feel, and auscultate, right? All right, circulation, what are we going to do right away to start supporting this gentleman's circulation besides the direct pressure on the scalp lacerations? 2 large bore IVs, right? That's going to keep us safe. And then he's a little hypotense. So do I want to address that? Yeah, because he's got a head injury and he's intoxicated. And if somebody has a head injury, I want to try to keep their systolic pressure closer to 120. So he's hypotense. The brain needs to be perfused. We have to overperfuse them in trauma to mitigate that increase of intracranial pressure. So we need to resuscitate him. What are we going to get? What's a resuscitation fluid of choice? It's definitely blood. Okay, whenever you lose blood, you're going to replenish it with blood. If somebody came in and they have vomiting and diarrhea from the norovirus, I don't give that patient blood. We give them crystalloids because they've lost a lot of fluids, all right? But usually if you've lost blood, you replenish it, or whichever fluid you've lost, you replenish it with the appropriate fluid. In trauma, crystalloid is bad. They've done studies with as little as 250 cc's of crystalloid, meaning lactated ringers, normal saline, as little as 250 cc's can cause a dilutional coagulopathy, and that's bad. Okay, all right, good job. So why is trauma such a big deal? There's a lot of trauma happening, right? It says here over 40 million annual visits in the US. It's the #1 cause of all children and all adults under the age of 46. All right, it used to be multi-system blunt trauma that was the leading cause of death in children. What's the leading cause of death in children now? Death by gunfire, okay? And that's because of mass shootings. That's also because of suicide, unfortunately, or accidental shootings with firearm accidents in the home. That is superseded as of, I think, 2022, multi-system blood trauma from accidents and motor vehicle accidents as the #1 cause of death in children. In grown-ups, it's still kind of a mixed bag. A lot of it's multi-system blunt trauma, man-on-man violence. Okay, why is there so much man-on-man violence? Machismo, right? All that testosterone. There's some other violent acts happening, but also a lot of motor vehicle accidents are caused by young men and their crazy driving. I know y'all like to think that we're the worst drivers, and maybe we are in our own way, but we're less aggressive just statistically. Anyhow, it accounts for about 50% of all deaths in younger people. And of the people that actually survive, they have some sort of ongoing sequelae. So it's bad to be majorly injured, right, from the trauma. And the reason why they die is usually instantly from like head injury, chest injury, or vascular injury. What kind of vascular injury? Yeah, you tear your aorta, right? That's pretty bad. Chest injury, you just completely compress or squish all the important organs, and of course head injury is really high on the scale. So back when I was a kid, I have vivid memories of standing in the front seat of my mom's car with my McDonald's cup, and I would just stand there while she was driving. I would jump from the back seat to the front seat, you know, the late 70s. It was pretty cool to do that. There was no airbags, there was no seatbelt laws. Anybody that old to remember that? Kagan said, okay, if you think you're my peeps back there. Okay, so back in the day, it was like the Wild West. If you got injured, you know what they do? They come and scoop you up and take you to the nearest facility. It can be like a tiny little minor emergency center that has no capabilities whatsoever. And guess what was happening? People were dying, which is bad, okay, for people to die. And so finally, it wasn't until 1990. How many of you were born after 1990? Most of you. Okay. Okay. Anyway, moving on. In 1990, Congress finally passed an act that said, listen, there's got to be designated trauma centers. And these trauma centers have to have a certain capability and criteria of certain kinds of specialties and disciplines, like surgeons, like orthopedists, maybe some neurologists or neurosurgeons. They have to have these things. And this model is going to serve to help prevent death, okay? And we're going to designate these hospitals as trauma centers and give them money and resources, but they have to do some certain things. So these trauma centers have to meet minimum admission requirements by volume. So they have to have at least 1,200 trauma patients annually and 240 admissions. And they have to have high injury severity scores. So people who are legit injured, okay, not just they have a toe fracture, I mean like legit injured. And they have to have a surgically directed critical care service. At BAMC, we had SICU, then it went to STICU. Is it back to STICU? Or is it surgery ICU? STICU? Yeah, surgery trauma ICU, okay? They kept changing the names, but it has to be a special critical care service directed at surgery and these very injured patients. They also have to be a teaching hospital. So you have to have residents at these nice trauma centers. Why is that? Well, these residents have to learn from that expertise, from that high volume, high acuity patients. They also have to conduct research. So the benefit of getting those patients, besides funding, is they get to do research and they get to publish this research so the rest of the world can learn from them. And this is the case, and then the military has kind of been at the spearhead of a lot of changes in trauma management with the Iraq, Afghanistan war. They've actually changed the way civilian trauma systems have conducted their own trauma. Okay, so that's pretty cool. Did you guys know that about trauma centers? They get funded, they have to have residents, they have to publish, they have to do all these things. And so in a well-run trauma center, if a patient comes in who's significantly injured, they undergo a multidisciplinary evaluation. So we have trauma surgeons, orthopedic surgeons, we have ER folks, we have anesthesia, we have all these people, x-ray, nurses, all at the bedside. And ideally, they come in the trauma bay, they get stabilized, maybe they go to CT, then they go right into their little surgery ICU, or right to the OR. And it's well run, smooth, quick handoffs, everybody's working together. Does that sound like the way you envisioned it? It's pretty good. Or do you just envision chaos, like the movies? Sometimes it can be that way. It depends on how prepared you are. It should be smooth. And they usually have specific triage categories or information. So for instance, EMS will come to a scene and they'll see a traumatically injured patient. They have to decide where to take that patient. So if it's a burn patient, for instance, they're going to preferentially try to get that patient to BAMC because they know that BAMC is a burn center. If there's if they suspect a major head bleed, they may try to take that patient to University or St. Luke's or something like that. So these pre-hospital folks are aware of the patients and the capabilities within the city. And of course, in the pre-hospital focus, they focus on the MARCH algorithm. Have you guys heard of that? Most of you should have. It stands for massive hemorrhage, which is our X, airway, with C-spine control, breathing or respiration, same thing, circulation, and hypothermia prevention is where the H comes in. But we do that kind of simultaneously in our X, A, B, C, D, E, F, G approach, all right? And do we agree that patients are kind of treated into really 3 main phases, but 2 pre-hospital and hospital phases? Does that sound fair? Especially for all of you with that prior experience. There's some treatment and care that goes into the patient at point of injury, and then they get into the hospital, and that's a whole different ballgame once you get to the hospital. So how does EMS know who to take where? Well, they have to know their local capabilities, but there's also a set of MedCom type criteria or trauma system entry criteria. And some of this is like, are they hypotense at the scene, indicating probably a major vascular bleed or internal hemorrhage, so they're gonna take them to a trauma center. They consider the injury pattern, like is there a penetrating injury to the head, neck, torso? Was somebody killed during that motor vehicle accident, indicating high mechanism? Maybe that person will be taken to a trauma center. If they fall greater than 20 feet, or they're ejected from the vehicle, or if they're elderly, or if they're on anticoagulation, or if they're pregnant, or if they're a child, there's all these criteria they know to take them to a trauma center. Does that make sense? Seems like common sense, right? All right, so what happens in the pre-hospital phase at the ER when we're getting a call? There's literally, is it still a red phone that rings at Ramsey? It's a red phone. What's that?
It changes down to quacking.
Yeah, it's a duck quack call. It used to ring, like, and it's a red phone, and now it sounds like a duck. It's like quacking. Anyway, it's really annoying. But anyway, you know that a trauma call is coming in, and there's these little sheets of paper. The little phone will ring, and they'll like, hello, Nancy, and they're like, oh, this is EMS number or whatever. We're en route with a 46-year-old male ejected from vehicle, a 45-year-old male ejected from vehicle, intoxicated, current vitals are this, blah, blah, blah. We're 5 minutes ETA. They hang up the phone. Or 10 minutes, or whatever it is. So what do you think the rest of us are doing at Ramsey during that time? We're prepping. So you got this really calm radio DJ voice come over the microphone. This is trauma team to the trauma room, trauma team to the trauma room. Have you guys ever been at Ramsey and heard that?
Yeah.
Okay. So what we all do is we all kind of nonchalantly kind of walk up, we put our little yellow gowns on and face shields, and you always want to have eye pro. And we have designated positions and jobs within that trauma. And usually we're prepared at least 5 minutes out, okay? We want to have everything prepared. So the trauma bays are set up a certain way, but based on the information that EMS gave us, we may have additional things set up, like a chest tube set ready to go. We always have glide scopes or optical laryngoscopes or a CMAC set up in the rooms. There's always some chest tube sets, but there's also other things in the Pyxis that we might start drawing up and getting ready, okay? So we got to do that. And a lot of times when the EMS gives us that initial report, that's called a MIST report. Have you heard that term before? They're telling you what the mechanism is, what injuries the patient has, what are their signs and symptoms, what did they do for treatment, and they usually give vital signs and then estimated time of arrival. All right, very important. So in that pre-hospital phase, all those things that we don't have to think about, they're trying to gather as much information at the scene as they can. They're looking like, hey, it smells like a chemical. Maybe there's some chemical exposure. This elderly person is a single vehicle accident. Did they have a medical event and then run off the road, or are they just terrible drivers because they can't see? They're considering all these things that we don't have to worry about once we receive the patient. Like, in other words, we don't have to worry about our scene safety, but we try to gather as much of that information from EMS. And sometimes EMS doesn't have the full picture. But sometimes there's witnesses, and they can kind of give input, or family members, or other people in their vehicles. And we want to try to get as much information as possible if they're in the pre-hospital setting, and then that information gets transferred to us at Ramsey. And so prior to them arriving, after you hear that little call over the intercom, we're designating roles. Hey, I'm going to be at the head. You're going to be at the foot. You can run this one. How about you? You take right side, your left side. The nurse goes in there to describe. Everybody knows their jobs, and it kind of looks like this. I'll show you a little cartoon in just a moment. And so as soon as that patient starts coming in, we start gathering that information from EMS and kind of evaluating that patient from our own perspective. And this is what it usually looks like. So this is a trauma diagram, and this is in a trauma center. Okay, do you think it looks like this if I'm at a little 1 battalion aid station? No, good luck even having enough people to stand around the patient, right? Remember, we're at a hospital right now. You're gonna put on your hospital emergency medicine PA hat. So usually we have a team leader, and they're standing at the foot of the bed. And we usually let second or third year residents, ER residents, be a team leader. It can also be a staff physician or on staff days, or sometimes it's a trauma surgeon, or sometimes they're all standing there. Occasionally you'll have like a younger, first year or second year resident doing it. You can always tell just by looking at them what year of residency they're in. If they're first year, for some reason, they're a little insecure still, and they're kind of standing there with their arms crossed, they're kind of uncertain. They keep consulting with their consultant, whether it be a trauma surgeon or the ER staff doc. When they're a second-year resident, they kind of stand with a little wider stance, they build more confidence, right? We've been building them up. And by the time they're a third-year resident, they come in with cowboy boots, and they're like standing like this, okay? They're running the whole thing. It's true. Tell me it's not true. They're literally wearing cowboy boots. All right, so they're standing here, and they're not engaged in any procedures at all. Why is that? Yeah, they need to see the big picture, okay? That's really important. When you're doing a task like intubating, or doing a central line, or doing a chest tube, you're focused on that task, you lose sight of the whole thing. You all, as military PAs, will be tasked at some point to do it all. You have to run the whole thing and maybe do a task like airway, or a chest tube, or a central line, and still try to keep the big picture going. But we have the luxury at a trauma center of having multiple people. So we have somebody standing here, there's usually a scribe, usually faculty, and there's usually a couple of faculty, a faculty surgeon and a faculty ER physician standing there. Then we have a right side, left side person. That's usually, it could be an ER resident, it could be a PA student, it could be an EM PA, right side, left side. So the right side, left side people go clavicles down. So this person on this side is going clavicles down here, and they're doing a full check. They're auscultating the chest, they're pushing on the chest, they're checking the extremities, they're going down the pelvis, they're going all the way down, pulse motor sensory, doing everything on that right side. If that right side needs a chest tube, guess who does it? The right side person. This is always to the patient's right, okay? Same thing with the left side person, clavicles down, they're doing that. We have somebody at the airway, they're doing clavicles up, okay? They have bilateral clavicles up. And their job is to do airway management. So if they need to be intubated, they're gonna do it, or any kind of airway adjuncts. If the patient is controlling their own airway, they're gonna ask them their ample T history, right? Allergies, meds, last oral intake, what happened prior, any of the last time they ate, what events led up to the accident, and their last tetanus. Because of course we wanna get some life-saving tetanus shots in the trauma bay, okay? Is that how you guys learned it before? Have you guys learned how this trauma team works together? It's kind of an interesting, and this is the way most people do it. I've been at several trauma centers, and this is kind of the way that most people do it. And there might be some slight variations, but this is in general how it goes. Usually in between here, you'll have some medics getting access, or nurses at the head of the bed, ideally next to you. It could be an anesthesia person, whether it be a resident, a CRNA, maybe just an RT, respiratory therapist, somebody there to help you, not just an RT, but somebody. You need those folks, right? Somebody to hook up the patient with a ventilator, someone to help you with your airway management, maybe hand you stuff if you have to intubate. And then everyone just kind of is really quiet until they're told to communicate. In other words, the head of the bed person, clavicles up, is getting their ample T history from the patient. They're feeling the chest, listening, looking at, checking for any kind of tracheobronchial tree type injuries. If the patient's phonating, looking in their ears, looking in their eyes, they're doing pretty thorough. And getting that ample T history. They're doing all of that quietly, and then when the scribe says, okay, I need airway. Okay, airway, I just intubated with the 7.0 ET tube, I'm 22 at the T. I use the glide scope. We confirm bilateral breath sounds, we have end-tidal of 35, there's colorimetric change, they're communicating. Last, before I intubated, the patient said he had no allergies, he's not on any medications, blah, blah, blah. But that person isn't speaking to we're told to. Does that make sense? Okay, and then same thing with right side, left side person, and then the team leaders making decisions. And about, towards the back there, you see a giant screen on the next one. This is the old trauma bay before we got the big screen TVs, and this is kind of what it looks like. He's a trauma surgeon, but we have the resident here leading it, they're the team leader, we got an RT, we've got nurses in there getting access, we've got a ER resident, we got our trauma staff, standing there, like just watching the whole thing on staff. I will jump in if you guys screw this up. And maybe an ER staff as well. And this is what it looks like now. And you can see it's pretty crowded. There's a lot of people in there, right? Do you agree? It seems like a lot of people. There's so many people that we actually put red tape on the floor now that if you're not actively participating in resuscitation and you're just there to watch, you have to stand behind the red lines so that you're out of the way. But now they have these big screen TVs, and currently all that's displayed on them are vital signs. But when they first got them, they used to also display your airway stuff. So if you're using a CMAC or a glide scope and you go to intubate, the entire room is playing armchair quarterback, because they could all see you intubating, right? Go left, go right, and it's like, you're like, go left, I got this, I think. But now it displays the vital signs and end title, stuff like that, so everyone can see what's going on. And what you can't see is on the opposite wall, where the airway person is facing, is a big GCS reminder, because we're terrible at calculating that, especially under duress. Okay, so we talked about some of this stuff. What is the primary survey? Do y'all need a break yet? No? Driving on? All right, maybe in about 10, 15 more minutes? All right. So we talked about the primary survey. But some people are confused. When does it start? When does it stop? It starts when you, in your ER, is starting to evaluate the patient. And we go in a stepwise fashion. X for exsanguination. We're going to stop all kind of bleeding that we can stop. Especially if it's extremity bleeding, what are we going to do? Tourniquet on it, right? High and tight tourniquet if we have to, or if we're exposed, we could do a few inches above the wound. How high above the wound should we put the tourniquet? Yes, there's some general different rules, right? Somewhere between 3 and 6 inches, 2 and 6 inches, depending on where you read. It depends. If the partial amputation or major vascular injury is intra-articular, you may have to go up further onto the femur to get good real estate to compress that tourniquet between the intact bone and the tourniquets. So if there's a disarticulation because of the mechanism, then it may all just be too squishy, right? So we've got to make sure we stop all bleeding first and foremost, because that's what's going to kill them first, and that's the #1 cause of death after any kind of trauma. Airway plus C-spine, do they need assisted airway or not? Okay, we talked about that. Breathing, we're going to look at these things, chest wall motion, penetrating injuries, any kind of tenderness, bruising, flail chest, crepitus, subcutaneous emphysema, and we're going to consider rate and oxygenation, right? Circulation, now quickly we can assess this before we even get a blood pressure. What are some good parameters that we can check to kind of get an estimate of their systolic pressure? Yeah, you're going to go radial pulse first. So if you check a radial pulse and there's a strong radial pulse, what is their systolic pressure-ish? 70 to 80, depending on who you read at, to 90, depending on who you read, okay? It's not an exact science, all right? If they don't have a radial, where are we going to check next? We're going to check femoral, okay? And what's that blood pressure-ish? 70, 60, okay-ish. It depends on who you read, okay? And then lastly, if there's nothing there, you're going to check for carotid, right? They should at least have something there. That should correlate with a systolic pressure of 50 to 60, okay? Ish. All right, so that's important. And then we're going to get IV access and optimized circulation, trying to get that systolic pressure up to at least 90 or 120 if we suspect a TBI, right? Disability, neuro exam, GCS, pupillary response, that's important. And then we do a quick pulse motor sensory on the extremities, that's important, right? As part of your disability. Exposure, remember, you get them trauma naked. And just to be clear, you're getting your patient naked, not yourself, okay? When you continue to work in your specialty, make sure the patient is the one that gets naked, okay? And then FAST for EFAST, and then fingers at the end after you log roll the patient. Now, like I said, not everybody needs an EFAST, and it's funny, when we're all tackling a patient, we're all on right side, left side, airway, you see this one little hand come in with gel, and they're coming in trying to do their EFAST in between people, and their screen's all the way over here, and they're trying not to get in anyone's way. And that's literally how it happens. So there's a lot of stress on y'all, especially for those of you staying here during phase 2. Because they'll be like, go ahead, go in there, do it at EFAST. And you're like trying to get in, and you can't get in, and you get gel wiped off, you gotta reapply. It doesn't go as smooth as you'd hoped. Anyway, and then G for go to the CT scan if you're able to. Okay, a lot of this stuff you guys know because you're military providers, right? This is a different, I'm giving this similar lecture to South University up in Austin. These folks have no idea about this kind of stuff, about tourniquets and things like that, but y'all know, right? So what kind of tourniquet is that? It's a cat tourniquet. It's the most common that we use, right? Has anybody here put a cat tourniquet on a patient before? Yeah, there's, this is like the 7th generation. That means the other 6 kind of stuck or broke or something was wrong with them, right? They keep getting better. It works. The whole idea is we stop external bleeding, and we can only put the tourniquets on the extremities that are amenable, right? What if there's a junctional wound? What do you do with that? Junctional meaning axillary, neck, groin. What do we do with that? Pressure, or you can pack, or you can use hemostatic agents, right? Like combat gauze, stuff like that. Okay, good. All right, so we want to stop any kind of bleeding that we can possibly stop. Is this a good point for a break? We're gonna keep driving on a few more minutes. 10 more minutes? All right. All right, airway. Now we talked about this before. How can we tell if somebody's airway is patent or not? And they're maintaining their own airway. Yeah, they can speak, they can phonate, and they're swallowing their secretions. Remember, a gag reflex is not a good indicator, okay? I'm from the Midwest. People did stupid stuff, right, out of boredom. And there's always that crazy circus freak that likes to tell you that they don't have a gag reflex. Have you guys ever seen that? Yes. Thank you for not the only one. I mean, it's not me. I mean, just to be clear, I knew people, but it's not a reliable indicator. A lot of old literature says assess for gag reflex. But the truth is, before we intubate, a lot of times, especially if we've sedated and paralyzed them, we're about to do RSI, we will get a tongue depressor and check, because if they're not sedated or paralyzed enough, we don't want to go in there, so we will check real quickly, but we know, and that's gotten confused. In general, in order for someone to maintain their own airway, they need to be able to swallow their secretions with phonate, okay, or both, ideally.
Is there any validity to, I know everyone's like, yeah, like the whole gag reflex, whatever, but the vibration of the eyelashes.
So that can help determine if they're deeply sedated and stuff. A lot of times, that corneal reflex is one of the last things to go, especially with the paralytic. But every now and then, they can still have a gag reflex. So a lot of times, I'll check real quick first. Or you can actually start inserting the laryngoscope blade, and then if they start gagging, or you just kind of, okay, let's just calm down for a second, let's do another 30 seconds or so, and then reassess. Because what you don't want is for them to vomit. And we're going to talk about this a lot in the airway lecture. The worst thing you could do, besides not noticing that you've intubated into the esophagus, or decided not to intubate when you should have, is to do it too soon and they vomit. Okay, that's bad. Okay, so inspect for foreign bodies, maxillofacial fractures. We talked about that. How do we open up the airway? You can do a jaw thrust, or a lot of times at the head of the bed, we'll do a little scissoring technique where we, like you're at the head, you're gonna just scissor your fingers opposite. So I'm gonna push the jaw down with my thumb and pull the upper incisors down with my middle finger. So it's like a scissor technique, and we're gonna practice that when we do the airway stuff, and then during the EMED lab, just opening the airway. And we do maintain inline stabilization, but I will be the first to rip that C-collar off somebody right away if I have to intubate. That C-collar is now in my way. It's not saving that person's life. The initial injury is done. It's not been proven to prevent any kind of secondary injuries after the initial. All it is an obstruction to our airway. That being said, I'm not going to throw the head around and be careless. We're going to do inline C-spine immobilization, and I have some pictures of that. There's some adjuncts that we can use for airway before actually intubating. The NPA, anybody ever use those still? Yeah, they're pretty good stuff. What's the number one occlusion of the airway in civilian trauma? Okay, the tongue. What about in military trauma, combat trauma? It's still the tongue. So the NPAs will work to displace that, so you at least have some sort of airway security. And we do the worst things, right? We throw our patients down onto a gurney and strap them on their back. And so if they're obtunded at all, or if you accidentally give them too much medication or sedation or pain medicine, and they become obtunded or a little deep in their sedation, they can occlude their own airway with the tongue. So if you're going to give them medicines like that and strap them down on their back, at least give them one, maybe two NPAs. Okay, we want to make sure we secure their airway. If at any point during your exam they start vomiting, we're going to log roll the patient, suction them out, get all that vomitus out of the airway, because we don't want an airway mess, and we don't want to have to end up doing a crike unnecessarily. Remember, in trauma, this does not translate to civilian, medical patients. Trauma only, if the GCS is equal to or less than 8, we intubate. Okay, why is that? Yeah, because one of two things have happened if their GCS is less than 8 after trauma. What are the two big things that probably happen? One of two. They either have a huge brain injury, and that's why they're obtunded, or they've lost so much blood that the brain is not being perfused. both of which are gonna require intervention, okay? And we can't afford for that brain to become hypoxic at all. So we're going to secure the airway and be aggressive about it. Now, a little old person comes in and they get accidentally got 8 milligrams of morphine instead of 4, and they're just there because of belly pain, and they go obtunded and they lose their breath for a few seconds or minutes, not minutes, hopefully seconds. I'm not going to throw a tube in that person. I'm going to probably bag them or give them Narcan or whatever. But in trauma, we have to intubate if it's equal to or less than 8, all right? Agitated patients suspect head injury. They're not always belligerent because they're on drugs or something. A lot of times that can be rising CO2 levels or an intracranial hemorrhage, so think about that. Okay, this is just a picture. This person's intubating, okay? He's not in the best position, would you guys agree? That's not a good position. Now, unfortunately, downrange, our litters are low. I mean, they're not adjustable. I can't just like get a pump and make them come up to my level so it's comfortable for me. But this person is in a hospital, so they probably could have. But you can see the C collar's open. They've done the right thing. They are not letting that C collar obstruct their intubation. But they got their little friend here has his hands there maintaining inline C-spine immobilization. So we're still cognizant of the C-spine, but I'm not going to let it rule my airway management. Does that make sense? All right, I think this is a good place to stop. Let's go ahead and take a 10-minute break. This is a good place. By the time we got to A, if there was any life-threatening bleeding that was external to the environment, we've already stopped it, right? Remember, this whole primary survey thing that we're talking about is you don't go on to the next letter until you've intervened and stopped what's wrong with the current letter you're on. Exsanguinating hemorrhage, bleeding being number 1, and airway. You can't go on to breathing. It's not like, oh, I see he's choking on his broken teeth and broken mandible. I note that. Just let everybody know, scribe, note it. I'm going to go on to breathing. We don't do that, okay? We're going to stop what we're doing and secure the airway before we go on, okay? Just keep that in mind. And that goes for your vignettes, too, for your tests. Don't go to the next step till that one's been done. So if somebody gives you X, A, B, C, D, and all that's clearly spelled out, then you need to know, oh, I need to make sure I expose my patient and protect them from hypothermia. It's a very streamlined, in real life, we're doing a lot of these things simultaneously. And we're teaching you as if you're the only one doing it so that you always know a stepwise order. And I actually address my medicine patients like this too. If I'm in an ER and somebody came in and presented a certain way and they've changed, I go right back to my XABCD just like a trauma. I'm like, are they bleeding externally? No. Is the airway secure? Are they breathing? What's my circulation and vital signs and blood pressure? I go through that stepwise fashion every single time, and it will save you. Even though this is for trauma, if you keep that kind of stepwise approach, it's going to keep you on your toes. Okay, airway. Remember, airway management is important, and it's unnerving. Have you guys intubated? Anybody had to intubate before? Intubating is hard, okay? I used to think I was really great at it because I got to do a couple of deployments to Iraq. I did a couple dozen intubations because I had to, and then I came back and started TCMC and taught airway management, so I thought I was pretty good at it, right? And then I deployed to a cache where there's like anesthesiologists and there's vascular surgeons, and of course I did like 150 intubations that year, which is a lot, but it's still not enough to make me an expert. It's just a lot. They say you have to do hundreds and hundreds to be an expert, and I still missed every now and then. Like I would miss, and when I say I missed, like I would try once, I couldn't get it, I would try a second time, I'm like, I'm out. I don't know what I'm doing, it's just not my day. Today I suck. Maybe I'll get back on my feet tomorrow, but I'm not going to keep humiliating myself in front of these people, right? And more importantly, it's not my ego, it's about the patient. So I'm going to hand it off to somebody who can get this today. And just remember that. It's never a time of your ego when you're managing a trauma patient. So trauma patients are notoriously difficult to intubate. Why? Because they're messed up, they're bleeding, they're vomiting. They have stuff in them. Some of them only had one tooth to begin with, and they broke it off, but not enough to actually make it go out of their mouth. It's just dangling there to disrupt your airway. Okay, that's the truth. I mean, they come in like that, or sometimes they have dentures, and they didn't put them in, or whatever. And so a lot of times now it's standard to have video laryngoscopy in the trauma bays. So at Nancy, there's at least a glide scope in each trauma bay, or a CMAC, which is my favorite. I love the CMAC, but even in Uvalde where I work, we have a tiny little McGrath. So just make sure your unit, somebody buys you some sort of video laryngoscope if they're gonna expect you to do traumas, because these are all difficult airways and you want to set yourself and your patient up for success. We're gonna use an RSI technique for intubation, which we'll talk about. Remember, especially in the military, an indication for cracks. What's the real main indication for a cricothyroidotomy? It's the very last ditch effort in a failed intubation, right? Where we've tried a primary, secondary, tertiary, a backup method, and then last somewhere on that list is cric. So if I'm gonna try to intubate, if I can't get it with the ET tube, I have a backup of an extraglottic airway. If I can't get that, maybe I'll try a different extraglottic airway. Maybe I'll try, some different adjuncts, and then cric is usually last on my list. Okay, but most of the time when we cric somebody, it's from maxillofacial trauma. All right, so the worst thing you could do is when you see a smashed face, is be like, I think I might have to cric them, and just hesitate, and try all these things first, like I did during one of my first rotations. It's bad. So we'll talk about that. But remember, crics you always have a cric set in your airway set, and hopefully with a failed intubation, that's your last ditch. In fact, in the ER, less than 1% of failed airways end up being cric'd because of the failed airway. So it shouldn't happen. We have adjuncts, we have other things, we're in a controlled environment. Y'all might be in an uncontrolled environment, only have a couple different backup methods. That the decision to intubate is not one that's a light one, okay? We're gonna talk about that. That's why video laryngoscopes are in the trauma base now. Like I said, they have a huge TV. It's like a TV of shame, where everybody just yells at you, go left, go right, my left, your right, I don't know. And they're freaking you out, right? And the people in the back are probably these old crusty surgeons that haven't been intubated in 20 years, okay? Here we go, we got this glide scope. Anybody here used the glide scope before? It's a nice little thing. It's different than regular intubation. We're gonna talk about that during the airway lecture. With the glide scope, it's got a really hyperacute angle, different than your regular laryngoscope blades. With your regular laryngoscope blades, you usually do a sweeping motion to intubate. With this one, you have to put it midline and not sweep. And you're gonna lift with only a couple pounds of pressure versus 10 to 15 pounds of pressure like you would for regular laryngoscopy. So there's a trick to it. So I'm gonna have some of these out during our trauma lab so you guys can practice with them. There's all kinds of video laryngoscopes. Either way, you just want something to help you visualize the airway. I've seen somebody, this guy I work with in Uvalde, man, this patient crashed. He did a sideways, ghetto, gangster style intubation using one of these video laryngoscopes. He just turned the camera sideways and went sideways like that, intubated him like all messed up. Like, they got it. That's how easy these things make. I mean, he's that good, but also the video laryngoscope help. That's not ideal. I'm just telling you, sometimes you'll be put in weird situations. Anyway, there's all kinds out there. Remember, C-spine, immobilization is helpful, but make sure that that's not obscuring your airway, okay? I've seen people struggle with the C-collar on. Just take it off and do inline C-spine immobilization. And it's difficult airway sometimes. I've literally had to take the head of the patient with my hand and move their head around in order to get that airway right. Now, I'm not getting crazy and throwing them around and disregarding their C-spine, but really what's important is their airway. All right, breathing with ventilation. Remember, we're going to stop what we're doing if there's an intervention. So what are some things wrong with the tracheobronchial tree that would make us have to stop what we're doing and do an intervention? Big sucking chest wound, right? Okay, what else? Flail chest, right? We might have to intervene on that, right? See if there's broken ribs, and if the broken ribs cause a pneumothorax. There's some quick killers here in the chest. And the chest is anything between the chin and the belly button, okay? So there's some quick killers there. What else is in that area? I'm sorry? Yeah, you could have a cardiac tamponade, right? That's part of circulation that we might notice later. But somewhere around here, we might hear muffled breath sounds, right? Things like that. So there's some quick killers here: tension pneumothorax, a major hemothorax, sucking chest wounds, paradoxical movements, flail chest, that kind of thing. And we're going to stop and intervene. It's a big sucking chest wound. What am I going to do first? I'm going to cover it, and then what? definitively, they're gonna need a tube thoracostomy, right? Very good. Okay, we're gonna stop. So let's say during the airway portion, I intubated, I got to breathing, and I auscultated, and I can only hear breath sounds on one side. What does that might indicate? I could have had maybe a main stem intubation. Maybe there's a dropped lung on the other side, but maybe it's a main stem. So if it is, and you look down and the ET tube is 26 at the teeth, that's pretty deep. So we're gonna deflate the cuff, pull it back, we're gonna stop right there. Does it matter if there's a main stem intubation? Will it kill him? Not anytime soon, but it's still bad form, right? We wanna support the patient, not add insult to injury. So we're gonna stop, pull the tube back, auscultate breath sounds. If there's a hole in the chest, we're gonna put a seal on it. If there's immediate need or indication of a tension pneumo, we're gonna do a finger or a needle thoracostomy. Okay, I'll be honest with you, I've only done a single needle thoracostomy in the ER once. I almost never do it, I usually do a finger. I just take a scalpel and just cut into their chest and do a sweep. And that's one of the 3 times I've stuck myself with a patient, because when I did a sweep, there was a flail chest and the broken bone cut me through my glove, blood exposure, so keep that in mind. So now I always double glove. But I was like, I did a 360 sweep, cut myself like an idiot, right? Okay, so don't do that. Be careful. We do need to do a sweep, but do it gently so you don't cut yourself. Anyway, we're gonna intervene if necessary. Big hemothoraxes will usually use a larger chest tube, like a 36 French, but we're kind of going to smaller chest tubes, and in your practice duration, you're probably gonna get smaller and smaller. All right, circulation. We talked about 2 large bore IVs. We're going to, of course, by now we should have already stopped the bleeding that we can stop. If they're bleeding internally, who do they need? They definitely need a surgeon. We can't do anything about that, but we can optimize circulation by resuscitating them with blood products. Are there anything else that we can do for these patients? Give them TXA, right? How much do we give them? 2 grams, right? IV push, very good. And it's best in the first 3 hours after trauma, okay? Blood products, do we have endpoints of resuscitation? How much do we give? Yeah, until they're stable, but what does that look like? What is a stable patient? Is it just blood pressure? Is it blood pressure mentation? Is it blood pressure radial pulse? What is it? Yeah, a lot of times in a pre-hospital setting, we'll say if they have a radial pulse and they're mentating, we're done. If they have a radial pulse and they're still not mentating, that means they probably have a traumatic brain injury, right? So if you've resuscitated them enough to get their systolic pressure up to at least 90 and they have a strong radial pulse, and as long as they're mentating, that's probably good enough, all right? But in the trauma bay, a lot of times we'll kind of shoot for really close to normal. And if we think they have a TBI, or they're still a little altered, our systolic pressure needs to be higher, like 110 to 120. Titnelli says 110. The TC3 guidelines say 120. That's why I keep giving you a range. If I were you, I'd get it close to 120, all right? Okay, and so here's some of the other things we look at. Level of consciousness, skin color, peripheral pulses, heart rate, and then of course pulse pressure matters. And either Major Sandoval or Colonel Gomez will emphasize that in the surgery labs too. Any hypotensive trauma patient is considered to be hemorrhagic shock until proven otherwise. So if the patient is hypotensive and tachycardic after a major accident or trauma, that's hemorrhagic shock. You all agree? Yeah, there's no way that's neurogenic shock. Neurogenic shock looks different. How does a shocky patient that's bleeding internally present? Pale, diaphoretic, cold to touch, right? How does a shocky neurogenic shock patient present? Warm, red, hot to touch. They're peripherally dilated. So totally different, all right? And they usually have low heart rate. All right, because if you have neurogenic shock, and we're going to cover this in this final lecture, you're peripherally dilated, your heart rate's low, all that vagal stimulation is low, so everything's low. Whereas in hemorrhagic shock, your body's trying to compensate, so the heart rate's going up, the blood pressure's going down. Does that make sense? Okay. What is this on this hairy belly? Seatbelt sign, right? Is that bad? It can be. Is it always?
No.
No, now that we have airbags and three-point restraints, the seatbelt sign isn't as sensitive as it used to be like in the 80s, all right? In the 80s, if you had a seatbelt sign from a single lap belt, that's badness. Now it can 50-50 go either way. But if you have a seatbelt sign on a neck or a flank, it can be really bad. So always document positive SBS, seatbelt sign, or negative SBS for every trauma patient. No seatbelt sign to the cervical, thoracic, abdominal, or lumbar regions, or very clear when I document it, so that's important. Okay, so I don't make you memorize the classes of blood loss, but Major Sandoval will for surgery block 3. There's a lot of overlap with this block, and you'll have to know this. Just remember, in general, that you won't really see a change in blood pressure until they've already lost almost 40% of their blood volume. That's a class 3 hemorrhage. Otherwise, we compensate. We're not even tachycardic initially until we've lost at least 30%. And then once we lose 40%, they start having hypotension. So just remember, you've already lost almost half of your circulating blood volume to be hypotense. That's why we have such a low threshold to get blood products, because they need it, right? They've lost 40% of their blood volume. That's bad. Okay, so circulation, we said 2 large bore IV, 16 gauge peripherally in a perfect world. 2 is 1, 1 is none. And a pinch, if you can't get it, they'll do an IO, but that's usually to give medications. Through an IO, using this big yellow guy, which is a humeral catheter that you put here in the humerus, under a pressure infuser, which is a bag that you put over the blood, and it looks like a blood pressure cuff, and you squeeze it and get it all under pressure, or Belmont, and pumping it through the IO. Even with this catheter, you can only get about 60 cc's of volume per minute through an IO. That's going to take a long time to resuscitate somebody who needs 8 or 10 units of blood, right? That's not happening. So that's why this is not ideal. So a lot of times in trauma, we'll try a central line right away, and usually we'll go a blind subclavian, or we'll do a quick ultrasound guided subclavian, so that we can, and we'll do a single lumen, so that we can do large resuscitation. Okay, so we'll do that. And that's what that is. Okay, subclavian line. That's the best one, and that's the one. Now, if somebody comes in with sepsis or something like that, we'll do a right IJ, triple lumen. It's a smaller caliber catheter. It has 3 little ports on it, so we can do multiple drips at the same time. They get their antibiotics, their pressors, things like that. That's for a medicine patient. But for trauma, we do a single cordis catheter, and we'll usually do subclavian. Okay, this is the pressure infuser I was telling you about. This helps it go in quicker. This is what you all have in a pre-hospital setting or a military battalion aid station setting. In hospitals, we have things like a Belmont machine, which will squirt that blood in right away. We also have other fluid warmers and fluid to maximize flow rates. All right, we're still in circulation. Remember, if the patient is stable, we're going to go ahead and get them to CT scan because the surgeons want to know where the injuries are. If we think that there's a pelvic injury, we're going to wrap them and do a pelvic binder. And we're going to do that when? When do we put a pelvic binder on them? Yeah, usually when you're doing your head-to-toe primary survey, and when you go to roll the patient, and you're checking the back for step-offs, and you're sticking the finger at the F, right before you roll them back over, you got to shimmy that little pelvic binder under there, so when you roll them back over, you can actually secure it. That's usually when we do it, especially if they have an open book fracture. It's the only real indication for a pelvic binder is for an open book fracture. And so that's important because, again, you can lose all your blood into your pelvic cavity. We talked about TXA, and this is talking about receiving 1-to-1-to-1 ratio. Have you guys talked about that in any other classes? What does that mean, 1-to-1-to-1 ratio? RBCs to platelets to plasma. That's really good. What's better than that even? Whole blood. Whole blood's great because you have everything. You have coagulation factors, you have volume, you have oxygen carrying capacity, right? Really good stuff. So anyway, if we at least resuscitate, if we have blood products in a 1-to-1-to-1 ratio, we have a markedly decreased mortality, and we also want to make sure we try to correct acidosis and coagulopathy. All traumatic patients that are injured, even an isolated head hit with an internal brain hemorrhage, can have a traumatic coagulopathy. So if you have a significant trauma, you're already going to have a coagulopathy. And what are some things that we do that make the coagulopathy worse? Just think about what can we do to make them worse. Give them crystalloids. Yeah, let them get cold and hypothermic after we make them naked and we don't cover them. Or worse, we don't cover them, we put them on the back of a moving helicopter with the doors open going across Afghanistan. That would be kind of bad. What else can we do to make them worse? So when we're doing whole blood transfusion, that bag that we are filling up the donor's blood in has citrate in it. Citrate binds to calcium, and all traumatically injured patients have low calcium. So when we give the blood products, even though we're saving them, we're giving them a little bit of citrate, which is binding to their calcium, which is making the patient's calcium even more hypocalcemic. And that's part of your diamond of death. Hypocalcemia is bad, and I'll tell you, I saw it firsthand. When I was in Afghanistan and we were with the first MEF Marines, we would give hundreds of whole blood products to one Marine. I mean, we saw lots of them, but we would give hundreds, and you'd see Marines just lined up outside, and we'd be taking a unit off each of them and then put it into the patient, just boom, boom, boom. And we had THAM going, which is something that's a bicarbonate type solution to help with the acidosis. We'd have all this stuff going. And sometimes we'd even have to do a thoracotomy. We're doing intracardiac epi, intracardiac massage, or get our ventricles full of blood because we have a central line. We're putting hundreds of products in this person. If we got behind on the calcium, you could visibly see the heart stiffen and it was done. There's nothing you could do. And that was back in 2010 or something. So my point is that calcium matters. The heart needs it in order to conduct, and so you have to stay ahead of calcium. So we give calcium and TXA to all these traumatically injured patients. If they're getting citrated blood products, they get calcium. If they're not, you may hold on it, but almost everybody has hypocalcemia. We talked about this already. 2 grams TXA IV push. Is it safe? Is TXA safe? Sure is. I gave it twice the other day on my shift in Uvalde. I gave 2 grams to somebody who wasn't even, they were females with heavy menstrual bleeding, and that's how TXA was discovered, postpartum hemorrhage. But we don't sell it over the counter here, but guess what? In the UK, if you're a female and you want to go to the beach that day, but you're debilitated by your menses, you can just go over the counter, buy some TXA tablets, take 1,300 milligrams a couple times, and boom, you get to go to the beach and not have to worry about anything. That's how safe it is. So it's an anti-fibrinolytic. What does that mean? Stops your body from breaking down fibrin, but it doesn't make you throw a clot, okay? There's some theoretical risk of that, but that hasn't been proven. It just it keeps you from breaking down your own fibrin. So that's why it's important. Why is it no good after 3 hours? Why is it increased mortality after 3 hours if you wait for the patients? It's been longer than 3 hours when you give it to them. They've already rid of all their clotting factors by then. Sir?
Ma'am, the 2 grams slow push, is that like actual curriculum, or is it just like 2 grams just passing it?
So, yeah, that's a good question. So, there's a theoretical risk if you slam it too quickly, that it can cause hypotension. So guess what? Your patient's hypotense from their trauma, whatever, you're gonna know, probably not. So slow IV push, I think, are there any former nurses in here? What's a slow IV push? Couple minutes? For me, it's like 30 seconds, okay? I'm like, done. Okay, slow IV push. You should wait, give it over a couple of minutes, but in real life, that might be 30 seconds. But the risk is hypotension, just so you know. And if your patient's already hypotense, you're resuscitating them, it may not be a profound difference. All right, so we get in more to the calcium in the military lecture. Okay, GCS, we're going on to D now. Everybody okay going on to D? You're so over this lecture, you're like, let's get on with it. We still have to get all the way to G. All right, so D, again, your GCS, quick pupillary exam, quick PMS, right? Motor sensory of the extremities. And then if somebody's altered or having seizure-like activity, we always do a point of care glucose. We don't want to look stupid and think somebody has a head bleed or a seizure when really they're just hypoglycemic. So I think that gets asked a lot on your exams, especially in phase 2. Remember GCS, you guys learned this before. I am trying not to make you guys calculate it on this exam, but you need to know what to do with the number, okay? But my colleague, you still have to figure it for surgery 3, all right? And then in phase 2, my colleague also makes you figure it out. Here I have it where it says, you know, the eye stuff is easy because it's either spontaneous speech or pain, and the most they can get is a 4. The voice stuff is where people mess up a lot because we use a word like incomprehensible sound, and that means muttering, you know, like there's no formable words, versus an inappropriate word is they're still saying a word and it's a complete word, like, I don't know, turkey or something that doesn't go with any scenario, but they're still saying a formulated word. If it's incomprehensible, that's synonymous with inappropriate, which gives them a 2. Now, a lot of the scales say incomprehensible, so don't confuse that. If it says incomprehensible, that's the same as mumbling no discernible audible words. Does that make sense? It's almost like moaning. It's hardly nothing, and so that's only a 2. Did I get you guys last time? Confused is like they might know the month, the president, but they mess up the day. Or they're just a little confused about what happened. Maybe not the best historian. I think I'm on Lysander Pearl, I don't remember. But they're still kind of conversing with you. They're just not quite at their baseline. That's why it's really hard to kind of tease that out. But in general, in real life, the most important one of these 3, which one do you think is the most important as far as patients' outcomes? Definitely motor. So in real practice, we can get you on exam, oh, it was a 9, gotcha, you figured it was a 10, it was only 9, you know, that's fine and dandy. But in the real world, motor is the most important. That's going to directly correlate with patient outcomes and is the most easily reproducible of the 3 exams. And it really correlates with their outcome. The rest is subjective, and we all screw it up by 1 or 2 in real life, okay? I'll go right behind Captain Williams there, and he'll do a GCS, and maybe I'll do it, and I'll say, no, I'm thinking the 13. And he's like, no, I'm pretty sure it's 11. I'm like, I think it's a 13. You know, there's a lot of subjectivity, all right? So I try to make sure that if you know a definitive number, you know what to do with it, and then just for my test purposes, and because it's common sense for life, pay attention to motor. That's the most important thing on a patient, okay? All right, moving on. Disability. Some other things that we can do if we think somebody has a head injury. Remember I said keep the systolic pressure how high? At least 110, okay? The new literature is saying 120. 120 is better than 110. Also, what are some things that we can do to help them? Elevate the head of bed to how much? 30 degrees or more, and that will actually decrease intracranial pressure up to 15 millimeters of mercury by just doing that. You're letting gravity drain that intracerebral hemorrhage, and so they'll actually do better. We never hyperventilate a patient, all right? We never prophylactically hyperventilate a patient. Who is here? Who's been taught that before? Somebody has a TBI, just hyperventilate a little bit? Me too. You don't do it. That's actually really bad. Don't do it ever. Unless they just herniated in front of you and you can't do anything else, that's the only time to consider it. And hyperventilation is considered 20 breaths per minute. All right, that's like the high normal. Never prophylactically. And as far as somebody actually herniating, you'll never forget it if you see it. They'll scream and screech, and they'll start posturing and moving right away. I mean, it's real obvious. So that, and then they'll have vital sign changes. So remember our traumatically injured patient who's hypotense and tachycardic? Guess what happens to them when they're when they're actually herniating? What do you think is happening with their blood pressure and heart rate? They're becoming hypertensive because the body's last ditch trying to raise the pressure to overcome the increased intracranial pressure. So the body's blood pressure is raising as high as it possibly can go, and the heart rate's going down. That's called the Cushing's response, and you'll notice it. And they'll be shrieking and herniating. It's really awful. Anyway, so never, ever prophylactically hyperventilate. Okay, now we got to E. We got through D. Everybody cool with D? What is it? What's comprised of D? GCS. What else? Pupils. PMS. What else? Earlier I said it's also disability. So if they have like a big long bone fracture or unstable pelvis, if you haven't already, this is a good time to try to stabilize that. Okay, exposure. We're going to completely disrobe the patient. We cut all their clothes off. Of course, we try to keep them if they're if they're just remotely aware, we try to be, cover up their genitals, try to be a little bit modest for them, but obviously we have to check everything. And then at some point, we're gonna roll them. There's some schools of thought that think the FAST exam is best performed after you've rolled the patient, because in theory, you've jostled some stuff around in there, and so that you are more apt to get a positive FAST. That's not necessarily, it just depends on where you guys are in your resuscitation. It's not a hard and fast rule, but by this acronym, the FAST exam falls after, examining exposure and enrolling them. Again, rectal tone and gross bleeding is all we're checking for. You're gonna palpate down each vertebrae. You're feeling for step-offs, tenderness, things like that. Okay, we're also gonna take a quick look at the pelvic area and stuff like that. Just a quick look. This is still primary survey. This whole X, A, B, C, D, E, F, G is your primary survey. Okay, FAST and fingers. You guys know how to do a FAST exam because you nailed it and showed us all your ultrasound prowess last week. So proud of you guys. What do you see here? It's got some positive fluid. You guys know to take that out. And then if they're stable, even if they have a positive FAST, as long as they're stable, they still go to the CT scan. So stable vital signs, right? And then because the surgeons want to know. All right, let's get through these last few sections pretty quickly. Injuries of importance. So head and spinal trauma, we're going to actually cover in different lectures. Remember, not all head and spinal injured patients present, obviously. Sometimes they do, sometimes they don't. But we're going to do a rapid assessment of their mental status in the D portion of our ABCDEFG, and we're going to maybe do serial exams. Usually if we think there's a TBI, we'll do Q5 neuro exams every 5 minutes in the trauma bay. Every 5 minutes vital signs, every 5 minutes quick GCS. And then sometimes we'll do serial EFAST exams as well, especially if they're too unstable for CT and we're resuscitating them, we're going to keep looking, seeing what's going on. Can we send a patient to a CT scanner who's been intubated in the trauma bay and is on a ventilator? Absolutely. Now their airway and breathing is secure. All right. What if I intubated them, put them on a ventilator, notice that they need a chest tube, I put a chest tube in, I've got it sealed, all that stuff, can they go to CT? As long as their vital signs are stable, right? They're not still hemorrhaging somewhere. Yes. Okay. So if somebody presents like this, you're gonna know, okay, they probably have a head injury. You all agree? What is this thing called? Battle signs, and what's this? Nobody know why it's called raccoon eyes? Kind of looks like a raccoon. Yes, very good. I'm so proud. The ecchymosis actually spares the tarsal plate, so it almost looks like they have like reverse makeup on, or it kind of looks like when my kid puts on her makeup. She's 10. It's awful. But it spares the tarsal plate, the layering of the blood around the eyes. So they always have that white little line. And so this is indicative of what kind of fracture? Usually a basilar skull fracture. Okay. We know if a tension of the thorax is suspected, we're going to do either a needle or finger thoracostomy right away. And if the patient is stable, at some point we're going to do a tube thoracostomy. That's the definitive treatment. In trauma, it's not, let's watch them. If it's less than 25% or 20%, no, in trauma they need a tube, all right? In spontaneous pneumothoraces, that was a different story. We've moved on, now we're in trauma. Now you guys are trauma PAs. You know what to do. All right. Cardiac tamponade, can we see this on a bedside EFAST? Yes, that's one of the things you're supposed to do, right? Remember when you did your subxiphoid view or your parasternal long, you're looking for that pericardial effusion. And if you see one, the next clinical question is the right ventricle collapsing during diastole? And if it is, there's tamponade pathology. And so how is that treated? Pericardiocentesis. Do we want to do it right there in the trauma bay? We're going to try to give them blood first and get their pressure up, and if we can stabilize them, we'd rather that happen in the OR with a CT surgeon, right? But are we prepared? Because we're awesome emergency medicine PAs? Sure, we're prepared if we have to do it. If it continues to accumulate, they develop tamponade, that's bad. And remember, it's not the amount of fluid, it's the rate of accumulation. So somebody with an autoimmune disorder may have had small fluid collections around the heart for months, 6 months, 8 months, a year. And next thing you know, they finally starting to have some shortness of breath and they have several hundred cc's in there versus that church Bible study situation gone wrong and somebody got stabbed and then all of a sudden 100 cc's of blood accumulates around the heart, that rapid accumulation can be enough to cause tamponade, okay? And so Bextrad is almost never there, less than 10% of the time. But there's other signs, and you can see it really quickly in your bedside ultrasound, which is that diffusion with right ventricular collapse. What are some other cues that somebody might have tamponade? It's usually from penetrating trauma. In fact, a stab wound to the anterior chest is probably one of the more common, or it could be a bullet wound, but usually it's a stab. Narrowing pulse pressure, hypotension, all of those, right? But the good news is we do the EFAS and we can actually see it. It's pretty good. Okay? This is what tamponade looks like, especially if the lights are out and you guys can see. Okay? Is that too dark now? Y'all look better now. I'm just kidding, I look better now. I got a bad haircut, so I look better now. Okay, all right. All right, so tamponade, see it on the EFAS. You may have to do a pericardiocentesis. We're going to try not to. What if you saw a bedside tamponade with your EFAS, and then all of a sudden the vital signs stopped, and the patient dies right there? Do we do a pericardiocentesis or a thoracotomy? They died. We got to open up their chest and do a thoracotomy. If they're still alive, they get a pericardiocentesis. If they have died, they get a thoracotomy. All right, once they lose vital signs, when they previously had one, it's a thoracotomy. All right, good. Remember, we don't do a thoracotomy in somebody who never had signs of life from the scene. This is important because you'll get asked this again in surgery 3. You don't do it in people who've never had any kind of signs of life in the field. They have asystole when they present, and there's no evidence of a pericardial tamponade. They've been prolonged pulselessness greater than 15 minutes, or they have a catastrophic brain injury with brain matter exposed. I mean, what's the point of reviving the heart, right? Or if it's been blunt trauma. Why do we not do thoracotomies in blunt trauma? Don't we want to do everything to save these people? Why is it only good in patients with penetrating trauma? Yeah, if you have no signs of life from blunt trauma, there's probably more than one injury happening, right? There might have been a complete disruption of vascular structures, maybe tracheobronchial tree. You can't just open them up and fix one thing. The idea of the thoracotomy is you're opening them up and you're fixing one of two things. Either a direct trajectory from a stab or a bullet wound that hit a specific vessel that you're going to try to occlude, or more often than not, fluid blood around the heart causing tamponade, and you're going to make a little pericardial window, relieve that, and then do intracardiac massage and epi right into the heart, and then bring it back to life. That's the goals of the thoracotomy. They have already died. You are doing everything you can to save them at this point, or bring them back from died, okay? Bring them back, okay? Versus somebody with blunt trauma, they have too many other injuries probably. They're not going to be able to go get in there and fix that one or two things, right? So again, you've seen this video before. During my trip to Afghanistan, we did 17 ED thoracotomies that year, and like I told you, 3 made it out of there to the cache, to Landstuhl, but they both got, 2 of the 3 got septic and ended up passing away, and only 1 of those 17 actually survived and was able to throw a pitch at the World Series. So it's very futile. So remember, the main goal is to either put your pressure on one vascular structure that's bleeding, or to relieve a tamponade, which this is a tamponade. Big pericardial effusion, right ventricle is completely collapsed, all right? And then all of a sudden they go pulseless, that's when you would do a thoracotomy. If they're just right here and you can't get them to an OR, you're gonna go ahead and do that pericardiocentesis, and you wanna do it ultrasound guided, all right? We're almost there. Again, ED thoracotomy, it's when patients have penetrating trauma, witness signs of life, either in transit by EMS, or even in the trauma bay, they still had signs of life and then suddenly died. We have a very finite amount of time to intervene to make a difference. Penetrating abdominal trauma, I'm going to go over this in the abdominal trauma lecture. It's pretty simple. If you have an evisceration of bowel, that person needs to go to OR, right? The surgeon needs to run that bowel. That's pretty common sense, don't you agree? Bowels are dirty. It's hanging out of your, if you have omentum and bowel hanging out of your stomach, you probably need a surgeon. So that's when you go to the OR, all right? So that's pretty straightforward. Abdominal trauma is really easy. If they have an evisceration, they go to the OR. If they're just peritoneal after an injury, they go to the OR. If they're positive fast and hypotense, or just positive fast exam, they're gonna go to the OR. You know, if they're hypotense, you can't find another reason, and they have a positive fast, they go to the OR. So there's that's pretty simple. So we have penetrating and then blood trauma to the abdomen we're gonna talk about. I'm gonna briefly go over secondary survey. When does the secondary survey start? So if it's after the primary, what has happened in between there? We have done all these things, right? We've stopped bleeding, we've secured airway, breathing, we've gone all the way F, G, right? And then gone to the CT. But what if they were too unstable to go to the CT? Where did they go? They left your trauma bay and probably went to the OR, if you're at a trauma center, all right? You can't even do a secondary survey till all that's happened, all right? Or they're just not that injured, okay? They were in a fight, they're okay, they had some facial fractures, airway secure, now you can do a head-to-toe secondary after all those other things have been intervened on. Let's say you're in a small ER like in Uvalde and you have a trauma. You don't have a trauma surgeon, you're gonna do your A, B, C, D, E, F, you're too unstable for CT, you're gonna try to fly them somewhere. Now you're gonna try to document the best you can a secondary survey right before you send them. But you're not gonna hold up the medevac bird to do that. But the trauma center wants you to do as much of a secondary survey as possible if you're at a facility that doesn't have trauma surgery. Does that make sense? So you're gonna try to go, intervene, stabilize, get all the way down to the end. May not be able to go to CT, but try your best to document a head-to-toe thorough exam as much as possible before you ship them. Does that make sense? I know it sounds, to me, it doesn't make sense to me either. That's what Tintinelli says. And it's like a sticking point, I guess. If you're a receiving hospital, they want as much of a secondary survey as possible, but in the real world, sometimes we can't even get that far. We're still giving them blood product, we're still trying to resuscitate them, we're still doing this, and then the bird comes, and then they go, you know, and that's just the way it happens, right? So secondary survey is exactly what it sounds like. The entire primary survey is done, in whatever capacity or stability the patient is, and the secondary is the thorough head-to-toe everything exam. I mean, you're looking at every little nook and cranny on that patient's body. And what do we discover in secondary surveys a lot? Injuries we didn't see during the primary survey, like cervical spine fractures, a little finger or a metacarpal fracture, things like that. A lot of fractures, mostly C-spine fractures is the number one thing we find later. But there's a primary survey, a secondary survey that happens later, and then once they're admitted or whatever, the trauma team does a tertiary survey on them at some point, usually 24 to 48 hours later. And if they were so unstable during their primary survey, they got whisked away to surgery, a lot of times this stuff's not happening until 24 to 48 hours later. Does that make sense? But anyway, it's just like it sounds. It's a head-to-toe secondary exam. These are all the things you're looking for. You're looking at the urethra, you're looking at the meatus, you're doing all these things. We didn't really talk about adjuncts in our primary survey, but I should have emphasized those. What are some adjuncts that everybody does during the primary survey? I'm just going to go back a little bit to still in primary survey. What are some adjuncts we do for imaging? Do we do anything? We talk about the EFAS. That actually has its own little acronym. We can do the CT. That's the G. Go to CT if they were stable. Are there anything else that happens during the primary survey that we do on everybody? Chest and pelvis, an AP single view chest pelvis. I didn't emphasize that, and that's my fault, but I want to make sure I emphasize it now. Now you get to the secondary survey, you're going to look at all these things, repeat exams, maybe put rainy clips if the scalp is still bleeding on that guy from our scenario after we did direct pressure. We're going to look at the urinary meatus, the scrotum, maybe have to do what's called a RUG, a retrograde urethrogram if there's blood at the meatus, all right, before we stick in a Foley. Did you guys talk about that in surgery? You will, okay. Vaginal bleeding, if there's vaginal bleeding, you have to do a speculum exam on a female, things like that. These are those thorough secondary things that happen after all the life-threatening conditions have been ruled out, all right? And then, like I said, the tertiary survey is usually done about 24 hours later after. So let's say they came in, they were unstable, they got whisked away to surgery because of an intra-abdominal bleed. They get stabilized in surgery, they get put in the STICU, and then the trauma team will come and do a tertiary survey. And again, a lot of times, that's when they recognize those C-spine fractures or other injuries that were of lesser importance because they had life-threatening injuries to begin with that had to be addressed. Does So just to reiterate what I'm just saying, primary, secondary, tertiary exams and what those are entail. Imaging and lab testing, we do a rainbow of labs in the trauma bay. Okay, we'll check drug, we'll check alcohol, we'll do a venous blood gas. If it's an elderly person, we'll do tropes, stuff like that. But usually everybody gets a CBC chemistry, and we usually do it on a quick bedside point of care printout lab that gives us all the parameters right away. And then the imaging is an AP chest and pelvis always, and then the EFAST exam. And then if they're stable, they'll go to CT. And when we do a CT of these trauma patients, what CTs are we doing on them? Yeah, that's confusing, right? So we do, we call it a trauma six-pack is what we call it, but it just means, it's just fancy terminology for 6 CTs on most multi-system injured patients. So like a motor vehicle accident, rollover, we'll do 6 CTs on them. It's a head non-con, then we do face, neck, chest, abdomen, and pelvis with contrast. All right, why are we doing with contrast? Everything except for the brain. Yeah, we need to see extravasation if there's a bleed. Okay, that's really important. And can we see cervical spine injuries, thoracic spine, and lumbar spine injuries from that neck, chest, abdomen, pelvis CT? They can. They have to redo the images, but even though they're with contrast, they can actually see spinal injuries as well. So it's just 6 CTs, that's our standard trauma CT, it's called a 6-pack. The only thing that's non-con is the brain, everything else is with contrast. All right, and that's so we can see active extravasation of dye if somebody's bleeding outside of a vascular structure. We do all these blood things, like I told you earlier. We'll do pregnancy tests, things like that. If they're a young woman, if they're elderly, we might do an ECG, maybe a troponin level, usually. And then again, if you're at a facility that doesn't have trauma surgery, you'll try to do your best to do as much of a thorough secondary survey as possible before you send the patient off. They want that, they want it documented, just do the best you can. Everybody knows that you're resource strained if you're at a small hospital. Sometimes people will present, they're stable, their EFAS is negative, CT looks okay, they're stable but they're tender. Can we still admit those patients to surgery? If they're tender, if they're symptomatic? The truth is yes, we should. We should admit them for serial exams because sometimes there's a delay in bowel injuries and sometimes even retroperitoneal injuries don't show up as well, especially like duodenal injuries, diaphragm injuries, things like that. They will not necessarily show up right away. So if they're tender or peritoneal at all, even though they're stable, we'll admit them for serial hands-on exams by the surgeons. We're almost done. Most of the time these folks will get admitted if they're significantly injured or if they have head injuries or they're altered at all in any way or any kind of abnormal labs, imaging, things like that, or if they're just tender, even though everything looks normal, we'll go ahead and just admit them for serial exams. So otherwise, if they have none of that, they can go home. Any questions about what we covered? Did that the sequencing make sense? Is that kind of how you figured things to go, mostly? Okay, we'll spend more time kind of hitting on the individual things now. We'll have an airway lecture. We'll talk about chest injuries, chest tubes, that kind of stuff. We'll go into each one. Abdominal injuries, spinal trauma, head injuries. And right in line with all of that is heat and cold injuries for some reason, okay? I just threw that into this block, so I get to cover that. Any questions about anything? Okay, you guys enjoy your break. I'll see you tomorrow.